Hi, my name is Cliff Coleman. I'm a physician in the OHSU Department of Family Medicine. Health literacy and clear communication are related topics which we can use to help improve outcomes for all patients. These topics are important for all clinic staff, so this training is designed to help raise awareness for all of us. After today's session, you should be able to anticipate the health literacy challenges faced by most patients and caregivers. Describe the reasons why we advocate for the use of a universal precautions approach to health communication. Describe 5 clear communication best practices and describe one or more standardized approaches to improving the clarity in staff to staff communication. The outline is this. We'll talk about health literacy basics. We'll talk about a rationale for using a universal precautions approach to health communications. Talk about 5 specific best practices for improving communication, and then outline a number of standardized staff to staff communication skills that we can use to clarify our messages with each other. I'll list some additional resources at the end, a full list of references, and an optional 10-item post-test for those who are interested. Health literacy basics. So we'll start with a quote from George Bernard Shaw, who said that the greatest problem with communication is the illusion it has occurred. And this is going to be a theme throughout the rest of this training. The theme is that what looks like good communication on the surface between a staff member at the clinic and a patient, with 2 people smiling, nodding, taking turns, asking questions, answering questions, and at the end, the staff member asking, "Do you have any questions for me?" And the patient saying, "No, I don't have any questions," thanking them and leaving. What looks like good communication on the surface, the science and research clearly shows is generally uh, hiding the fact that there's miscommunication, that there's confusion, and that there's risk for not understanding. In the United States, we have a really big problem with health literacy. Over a third of US adults have low health literacy at baseline. This graphic shows us the results of a nationally representative survey of over 19,000 adults across the country, where the US Department of Education sent researchers into people's homes and gave them a reading comprehension test to see what skills level they were at. In this survey, 14% of US adults had what we'll call below basic health literacy skills. They were really only able to answer the most simple, basic questions on a reading comprehension test, the type of test where you would read a paragraph and then have a multiple choice answer or a fill in the blanks answer to choose from. The next group up, about 22% of adults fell into the basic skills category, which could answer a little bit more difficult questions. But neither of these groups, when we combine them, we see that's the 36%. Neither of them had the skills that were considered adequate for dealing with the really usual, typical kinds of communication demands that patients face when they come to see us at the clinic. The way that we're going to speak to them, the types of language that we're going to use, the words we're going to use, the concepts that we're going to be talking about, the forms that we're going to ask them to complete for us, and the written materials that we're going to give back to them to help them succeed in taking care of whatever their issues may be. These folks have skills which are really inadequate for those basic communication demands. Now, the rest of the population, about 53% have intermediate skills, which are better, and 12% have really high skills, which we'll call proficient. But all of these people are at risk for having trouble understanding health information at the time when they need it most. And if you think about how we all think and learn about something new, if a patient with higher literacy skills comes in and they're feeling sick, if they're in pain, if they're worried about what we're going to talk to them about, if they are worried about something else going on in their life, if they haven't slept well because of symptoms or taking care of someone else, all those are reasons why their cognitive or brain functioning is going to slow down. Their processing of information is going to slow down, and their health literacy skills are going to go down as a result in that moment. So we're all at risk for low health literacy at the times when we need it most. Now, literacy is really complicated and it is involved in virtually every single thing that we do at the clinic. So we've been talking a little bit about reading comprehension. Reading and writing is, of course, important to patient care, and I'll talk about that. There's also this idea about numeracy, which is the basic use of numbers and math in conversations. And one of the um, easiest to understand examples of this is writing a prescription instruction for a patient. We'll see an example of the prescription label that says take 2 tablets by mouth twice daily. And we'll come to realize that that's a math problem that's hard for a lot of patients to solve properly. These all fit into this idea of print literacy, and we put a lot of print literacy demands on patients. We ask them to come in and fill out forms. We ask them to read, understand, and sign consent forms. We ask them to understand and interpret prescription medication labels and take medications properly. Figure out the dosages on over-the-counter packaging. Follow written instructions that we may give them. Benefit from the patient education brochures and websites that we may direct people to. Keep their appointments on a calendar or a schedule and get to them on time. Follow signage to get to places that we may be trying to send them. And then correspond with us electronically through MyChart. Now, that's that's print literacy. There's also spoken or oral literacy, which is a huge part of what we do at the clinic. We put a lot of demands on people. From the moment they decide they need to get an appointment and call in, they'll have to navigate a phone tree, which is a spoken literacy demand. Once they get on the phone with us or get in to see us, they have to describe symptoms, perhaps, and do they have the vocabulary to describe them in a way that's helpful for us to narrow down the possibilities? They need to understand our vocabulary and the words that we're choosing to use with them and the concepts that we're trying to convey. Can they understand easily the verbal instructions that we're giving? And are those multiple step instructions broken down in a way that's memorable and easy to follow? And then when confusion does arise, are they able to formulate a question in their mind that would help clarify it? Or is the situation so confusing that they don't even feel confident in phrasing a question back to us? And then lastly, there's this idea of cultural and conceptual knowledge, which is basically what does a person have, what have they learned? People with lower literacy skills spend less time in their life reading things, so they learn less things about the world from written materials. They actually go to fewer years of formal education, so they learn less of that school-based education and learning, and grow up to be adults who might have different understandings of how the world works, how their body works, and how medicines and things like that work. So, for example, does a person have a concept in their head of what germ theory is? This notion that there are these invisible microbes that can get into a person's body, reproduce themselves, and create an infection that they can break out of that person's body and go to the next person, and so on. Does a person understand pharmacokinetics, which is what happens when I take a pill and swallow it and it dissolves and goes into my bloodstream? And where does it go and what does it do and how long does it stay before it leaves? Do they understand the mathematical concept of risk, which is based on probability? Most adults in the United States have very low numeracy skills, and understanding risk is very challenging for a lot of people. And it's very hard to understand important concepts like prevention to prevent something that hasn't happened yet if you don't have an understanding of what risk is. So for me to recommend getting a vaccine to prevent a viral infection is hard for a person to understand who has a hard time understanding the mathematical foundation of risk. Now, most adults in the United States can read and write, but reading comprehension is the big problem. So in this study, researchers took volunteers and gave them a reading comprehension test, and they kept everybody, all the volunteers who were reading at a sixth grade reading level or lower. They sent the rest of the people home. So lower skill readers. Then one-on-one in a private room, the researchers asked each person, or they handed them a pill bottle and asked them if they would mind trying to read out loud the prescription label. So 71% of these people could read verbatim the instructions that said take 2 tablets by mouth twice daily. And then the researchers said, okay, that's That's great, thank you. Now, if you wouldn't mind trying to show me or describe to me, how would a person take this medicine in a course of a day? What does that look like? Only 35% could demonstrate or describe that task. So they could read the words, but they couldn't turn them into action. Now, I'm going to show you a list of words here from a thing called the Rapid Estimate of Adult Literacy in Medicine. It's a screening tool that we use um, to measure health literacy skills in research settings. And I've got a trigger warning here to alert you that on this list of words, there's at least one word there that refers to a sexual trauma. I wanted you to be aware of that. This is a list of 66 words, and it would be on a laminated sheet. The researcher would hand it to the research participant and ask them to read out loud each of the words, starting with the left-hand column and going down, then the middle column, and then the right-hand column. And it turns out, if you can pronounce a word correctly, then you very likely have an adequate understanding of the meaning of that word. And if you don't pronounce a word correctly, if you mispronounce it, you very likely don't have an adequate understanding of the meaning of that word. So this is a very clever and quick way to get an estimate of a person's literacy skills in a healthcare context. So I'm going to just give you about 1 minute. I'm going to ask you to just quietly to yourself read this list, starting with the left-hand column and working your way over, and then we'll talk about it. Okay, if you didn't get through to the end of it, that's fine. What I want to point out about this list is that all the words here are kind of health or healthcare related. And it starts off with the sort of shorter, easier words, and it works its way into longer, more complex words. But none of these words are extremely technical or really far out jargon. These are the typical kind of flavor and type of words that anyone would expect to hear when they come to a clinic. Uh, and so now let's think about what that means when we score this thing. So so in the validation studies that looked at how to score this thing, they were able to show that if you can pronounce only 0 to 18 of these words correctly, you're reading at a third grade level or less. If you pronounce 19 to 44 correctly, you're reading at a fourth to sixth grade reading level. If you pronounce 45 to 60 correct, you're reading at a seventh to eighth grade reading level. And if you're pronouncing 61 to 66% correctly, you're somewhere above a ninth grade reading level. Now, this is important because the average adult in the US reads at an eighth grade reading level. That means half of the adults in this country read lower than an eighth grade reading level. And what that really might mean is that our average patient looking at a list like this may actually be unfamiliar with somewhere between, say, 5 and 20 words on a list like this. And remember, these may not be the exact words that a patient's going to encounter when they come see us, but this is going to be the type of language they're going to hear. And if an average patient comes in and spends a visit at the clinic and encounters a bunch of language that they're unfamiliar with or they don't lack confidence in their understanding of, we can start to understand how difficult it might be to take home a useful message and know what to do and actually do that successfully. Let's listen to some patients describing their own experiences in the healthcare setting and listen carefully for the words they use to describe what it's like to not understand and how shameful they feel and what they do to kind of conceal the fact that they didn't understand.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. Mm-hmm. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
We had a child that was physically handicapped that I had to do physical therapy on. I would show up on Tuesdays instead of Thursdays for the appointment. I would be exercising the wrong side of the body.
I had an abscess in a ear one time. Well, I had to fill out forms and I couldn't fill out, so I didn't go. I come back home. I ended up having to go to the emergency room that night because it burst.
Can you imagine what it's like, you being a patient and sick, and you know that you have limited skills, okay? And you're talking to an intelligent doctor like yourselves. And these people are using words that you really don't know because they're not speaking in layman's term, okay?
Right.
Most doctors are just presuming that everybody's intelligent as they are, and that is just not the case. So what you do, you come out of that room, that examination room with this intelligent woman or man thinking, God, I hope I don't make a mistake with my medicine because I did not understand anything he or she said to me.
The heart one capsule.
That's right, one capsule.
One capsule. I don't know what this is.
Twice?
Twice daily.
Okay.
Okay.
So how would you take this?
When I see it's not on there telling you how to take it. It say take it twice daily, but it don't say what time to take it.
Can you tell me which one is which and what you take them for?
That looks like my medicine that he gave me for the morning. I take that and the little pill that, no, this is this is lithium, isn't it? Yeah, that's lithium.
Okay. And what do you take that medicine for?
Don't ask me. He puts me
Okay.
on there and I just take it.
Okay.
Anything he tells me to take, I'll take it.
Okay.
I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
So there's a lot that we can unpack here. And I really want to key in on some of the language that we heard. We heard one woman say, you're in a room with this intelligent woman and man who assumes you're just as intelligent as they are, and that's not the case. She used the word intelligent. This woman here said she didn't want to reveal her sense of stupidity, and that was her word. And what we're hearing is that when patients don't understand us, they equate that with being not smart, or in their words, stupid, ignorant, or something else. And you can imagine what that would feel like. This is a very strong motivator that patients will tell us in research settings. They'll go to great lengths to hide the fact that they don't understand something at the clinic because of the sense of shame and embarrassment. And so they'll act as if they understand, right? And then leave not understanding. As the woman said, I hope I don't make a mistake with my medicine because I didn't understand anything they said. So this is that illusion that good communication is occurring. So our definition of health literacy is going to be this. It's going to be the ability to find, understand, and use health information and services to achieve our goals. And that means that health information, we want to try to make information that's easy to understand and that the person can feel confident in their understanding. We want our messages to be easy to act on so they can do something with it and achieve goals. And if it's related to services, we really need to think about what navigational barriers a person may have to achieving their goals. Now, low health literacy is associated with a lot of worse health outcomes. So here's some examples. People with lower health literacy are less likely to use preventive services like getting vaccines and getting cancer screenings. They're less likely to understand their medications and how to take them properly. They're more likely to suffer from chronic diseases that they need to try to self-manage. They're more likely to have trouble navigating through our healthcare system. They're more likely to use emergency services rather than coming to primary care, like the man in the video with his earache that turned into sounded like a burst eardrum where he ended up going to the emergency room instead of the clinic. More likely to need to get put in the hospital when they do present to care. More likely to get put back in the hospital after leaving the hospital. More likely to die from cardiovascular disease and other causes. And studies now showing that health literacy is a better predictor of racial and ethnic health disparities than the traditional measures of years of education and income. Now, this complicated slide is really just to show us that there's a lot, but from the time a person decides they need help till they actually get that help and try to navigate through our system, getting an appointment, getting to the clinic, getting into the clinic through the past all the paperwork, figuring out what's going on, maybe getting a prescription, all these things that have to happen, all these places along the way where people fall through the cracks, and especially people with lower health literacy fall through the cracks. So universal precautions is a solution for us, and it's a really important one. Let me just break down the rationale here, and then I'll explain what universal precautions really looks like. So we know now that low health literacy is really common, and that at least 36% of adults have low health literacy just at baseline, but that everybody can have low health literacy in the times when they need health care the most, when they're sick, scared, or hurt. We know that people hide the fact that they don't understand, and they're going to be motivated to protect that information and make it appear as if they're understanding us, even when they are confused. We know that from other studies that we as healthcare people can't tell when a person is understanding us and what they're understanding just by looking at them and talking with them. And we know that we have these screening tools. I showed you one, but for a variety of reasons I won't go into right now, they're not appropriate for use in a clinical setting. We only use them in a research environment. So what are we left with? We're left with this idea of universal precautions. And what it is it basically says, we need to treat everybody the same, with the same level of dignity and respect. We need to assume that every patient is at risk for not understanding or confusion around health information. We need to not try to adjust the complexity of our messaging to patients based on what we think we understand about their demographic backgrounds. And we need to use clear communication strategies as our baseline default with all patients every time. Now, when I say that last piece, there's often someone who'd be concerned that won't some of my highly educated, high income, high literacy patients be offended if I make the messaging simple for them? And the answer is no. In the studies that have been done on this, everybody, regardless of literacy level and socioeconomic status, prefers clear communication, simple messages first. Now, let's get into some of these best practices and see how this plays out. So we've got this dynamic setup. On the left-hand side here, this yellow arrow representing a patient's health literacy skills in that moment, remembering that those skills can go up and down based on how they're feeling and how distracted they are by perhaps symptoms or other things in their life. On the right-hand side then are the demands that we as agents of the healthcare system are constantly putting on people. And as you can see, the red arrow is much bigger than the yellow one, indicating that the demands we put on people are always overwhelming their skill set and their in that given moment. So our right-hand side of the model is us either delivering clear communication or often cases unclear communication. And what our job is to look at that and to think about how we can shrink that red arrow at every moment that we're working with a patient or a client, and to try to match their skills. Now we know what the best practices are. We've got good consensus from educators and health literacy experts on what clear communication practices we should be using, and I'm going to show you the top 5 here. We'll go through these one at a time, starting with this one, use of qualified medical interpreters. So qualified medical interpreters are trained medical interpreters. These are not, this is as opposed to lay interpreters who would be family or friends who are not trained as medical interpreters. In the law in the United States says that we as a healthcare institution must provide free of charge access to language interpreters at all points of contact. OHSU's policy in this area goes beyond that, and it says that we should not be using family or friends as the primary interpreter when we're working with a patient, but it would be okay to use family or friends in addition to a qualified professional interpreter. Here's why using professional interpreters is so important. When studies that have compared professionals versus family or friends, what we see is that professional interpreters make a lot less communication errors, improve patients' comprehension, decrease things like ordering unnecessary tests, decrease the risks of accidents, adverse events, and bad outcomes, increase people's ability to follow the plan, decrease length of hospitalizations for patients who are in the hospital, decrease readmission rates to the hospital, increase patient satisfaction, and decrease the chances that we're going to be sued. So there's really no excuse for us to not be using a professional interpreter every time when one is indicated. So maybe we need to figure out next is when do we actually need one, right? Now, obviously, we're going to recommend using an interpreter anytime that the patient has a language other than English listed in their chart. But an important scenario for us to consider are those times when a patient brings someone with them and asks that that person be their interpreter. I've brought my brother or my cousin here today, and I want them to be the interpreter. In that scenario is very common. And the easiest thing for us to do is to say, okay, that sounds fine, let's go ahead. But what we really need to do at that moment then is stop and say, that's great. I'm glad you brought your relative. That's going to be very helpful to us. I'd like to also add a professional interpreter into this. And your relative here can help us make sure that our professional interpreter is understanding you clearly and that we're all understanding each other. Our next best practice is going to be the use of plain language and avoiding unnecessary or undefined medical jargon. Now, medical jargon is the specialized language that we've either learned through our formal training to get ready for the jobs that we're doing, or we've learned it on the job. Some of those shorthand or shortcuts or abbreviations that we might use to communicate maybe faster or easier with each other. Sometimes jargon is necessary for patients to hear and learn, but that's very uncommon. Most of the time it's not necessary and it just creates unnecessary confusion. Rarely when jargon is used is it ever defined in easy to understand terms. Lots of kinds of jargon, and we won't go into in too much detail here. Just point out that there's technical jargon, which are words and phrases that really only have their meaning in a healthcare context. Things like glucometer, cardiologist, abdomen, right? People don't say abdomen at home, they say belly or stomach. And then there's these ideas of quantitative jargon, which are not really medical terms, but require some sort of medical interpretation. So the example here being, telling a parent to call the nurse if your child develops a high fever. What does the word high mean, right? It's not a medical term, but it needs some interpretation. In my mind, high might mean 103 degrees Fahrenheit. To the parent of the child, it might be 100. So there's some interpretation there. And then lay jargon. Lay jargon are words or phrases or ideas that have one meaning inside a healthcare environment and a different meaning outside of it. So an example here could be the word stable. If I say your vital signs are stable, to me, that means good. It means your situation is not changing rapidly. That's usually good. Outside of healthcare, stable might mean that something's not going to tip over. It's stable. Or it might be a place where you put the animals. Go put the animals out into to the stable. So you can start to see that there's a lot of variety there. Let's listen to some New Yorkers describing what the word hypertension means to them.
Can you describe to me what hypertension is?
I'm guessing it's when you're really hypertense. I have no idea.
No, but it sounds bad.
I don't know that.
Hypertension would be overactiveness in the muscles.
So is it when you stress a muscle or something like that?
No, actually in the mind, maybe. Hypertension.
Hypertension is like a mental disorder.
I don't have it though.
To be treated with the proper medicine.
Hypertension would be overactive stressfulness.
I don't know what medicine it is. Maybe Haldol, Prozac, Prolixin, something like that.
Okay, so hypertension, right, is a pretty common word. Most people have heard it. If you ask these people, have you ever heard the word hypertension? Many of them would say, yeah, I've heard it. And then you say, well, what is it? And they say, I have no idea. So just a good example of jargon that's really common to hear in our clinics. Here's some more examples. These come from our hospital. If you've been in our hospital, really any hospital, you're a patient lying in the hospital bed looking up at the wall across from you, there's usually a dry erase board there that's going to have some information about your situation and maybe your plan. And these are some examples. They don't include any protected health information here, but I just wanted to show you some of the wording and language that's used. This patient's reason for their visit is hypoglycemia. Well, people don't really use the word hypoglycemia, but they might say low blood sugar. So maybe we should use that language as well. This person's active issue is syncope. People don't really talk about I had syncope. They say I passed out. So we could do better there. This person's diagnosis is FX humerus R side. FX is short for fracture. Humerus is the big bone in the arm, and R with a circle around it means right. So this is a broken right arm. So why didn't we just say that? I don't know. Lots of other examples here we won't go into, but you can take a look at. Let me show you some other examples. This is a prescription refill request for 2 medications. The first medicine was Eliquis, and the instructions say take 1 tablet by mouth twice a day to prevent thromboembolism. Well, patients don't really use the word thromboembolism, so I'm not sure if this person will know about how concerned they should be and how important this drug is. It might have been better for us to say to prevent blood clot. The next medicine on here is duloxetine, which is used to treat depression and chronic pain. And the reason for this one was said it was for musculoskeletal pain. And musculoskeletal is misspelled as musculoskeletal, but that's beside the point. The real point here is that what does that mean to the patient? Could we have just said what their actual problem was? Like maybe it's for back pain. Continuing with this idea about prescription labels, there's a lot of different ways people who do write prescriptions, providers who are writing prescriptions can put these in a lot of different ways. We could say 2 tablets by mouth twice a day and put that into Epic. We've already seen that that's a math problem that some people will have trouble solving. Some patients will describe taking their 2 tablets at 8 a.m. and then 2 more at 10 a.m., which is doing what the label says, but is not what the intention was. The intention was to divide it up about every 12 hours. So some of the best practices that have been studied, we can say, include putting some time parameters around when to take it. Instead of saying twice a day and letting the person decide what that means, put some time brackets in there. Take 2 every morning and take 2 every evening. Gives a person a range to work with. And that's been shown to improve proper or correct dosing. Put the reason for the medicine on the label, right? So generally speaking, our prescriptions that come out of Epic don't have a reason on the label. They just say take 2 by mouth twice a day, but they don't say why. But putting the reason on there has been shown to improve patients' understanding. And then we should be putting that reason in using lay language for that, right? Instead of saying hypertension, which is what Epic might choose for us, it chose thromboembolism previously, we should be putting it in lay language like high blood pressure or blood clot or what have you. Our next best practice is avoiding information overload, right? Humans' brains can only handle so much information at one time. In fact, me talking to you now for so long, you've had to forget virtually all of the things that I've said so far in order to make room for what I'm saying right now. So this is a good example of that. For patients, the studies show us very clearly that in a typical kind of office visit coming to the clinic, average patient's going to remember 50% of what we talk about with them. 50, they're going to remember half of what was talked about. And we don't know which half that is. Is it the really important half, or is it the not so important half, or some kind of mixture there? Then, of the half of the information they do remember, half of that is wrong. So really, after a visit to the clinic, an average patient's going to remember and understand maybe 25% of what was talked about. So we've got to be careful about not putting in less important information into their head, because that might be what sticks. So some strategies for reducing information overload. I'm just going to hit a few highlights here. The first one is if I need to tell somebody something, I better find out what they already know about it, so I'm not repeating old stuff that's unnecessary. If I wanted to tell somebody about a new diagnosis of high blood pressure, I might ask them, what do you already know? What have you learned about high blood pressure? So I know where to start. And then I'm going to key in on 3 key messages, and these are them right here. What is this person's main problem? What do I think they should do about it? And why is doing that important? So if I answer those 3 questions, that might be all the information I would want to give that person. What's the main problem, what to do about it, and why? After I've given those 3 key pieces, I can certainly give the person an opportunity to seek more information if they actually want it. But generally speaking, people are very satisfied when you've answered those 3 main questions. But we can always ask, do you want more? Most people say no. Let me show you those 3 questions now in a visit summary. So here's a dot phrase that I use for visit summaries. It's .cc AVS. The CC is my initials. The AVS is for after visit summary. And you're welcome to take this if anybody wants it and modify it to be your own, but it just breaks it down into those 3 questions. Your main problem today was blank. For this problem, I recommend blank. Doing this is important because blank. And that for me makes the message really quick. I usually will put probably literally 1 sentence in each of these so it's fast, and it's organized in such a way that patients can really quickly find the parts that they need. Now, continuing with this idea of writing like a visit summary, when we're writing for people, we got to keep in mind people's reading skill levels, remembering that the average person's reading at an 8th grade reading level. So really what we need to be doing is writing messages more like a 5th to 6th grade reading level so that the vast majority of people can benefit from it. Let me show you an example. Uh, this is a first draft of a letter that we were going to send out to encourage people to get colon cancer screening from the clinic. And so this first draft, we kind of looked at it and we found some things that we thought we could improve. First, we looked at it and we said, well, there's some jargon in here that's not very helpful. We could fix that. I'm not going to read it out to you, but I'll just go point out some of the things we looked at. The language in it was really formal. We thought it could be made a lot more friendly and inviting. There was a passive voice being used in this first draft, and we thought we could get a little more active participation by using an active voice. We found some vague instructions that we felt could be improved, and we found one really long sentence that we thought was going to reduce people's readability. If we plugged this text into a readability calculator, what it told us was there's 103 words here, and it took about an 8th grade reading level to understand it on the first read. So we worked on this first draft. We wrote a second draft, and in this second draft, we actually shortened the text by about 30 words, and we reduced the reading level down to 4th grade reading level. So now the vast majority of patients at least will have access to the information here, won't be excluded by the readability threshold. Moving on. Our fourth best practice is going to be how to encourage people to ask clarifying questions, right? We know now that people sit with a lot of confusion and hide that from us. Can we somehow get them to ask some clarifying questions? The way it's been typically done is we use this closed-ended phrase, do you have any questions? Right? And it's closed-ended, meaning you can only get really like two answers, yes or no, right? And what are most patients going to say, especially if they're confused? Most people who are confused are going to want to literally hide that from us and say, no, I don't have any questions right now. Or they may be so confused that they don't feel like they can formulate a, a question that's going to sound good or that's going to be smart, right? So they just say, no, I don't have any questions. So we want to kind of flip this and see if we can get out of that mode and do this by using an open-ended phrase that helps people, encourages people to start talking a little bit. So the open-ended phrase for this is, what questions do you have? It's encouraging. It anticipates that they should have some questions. It's more inviting. And at least it hasn't sort of closed the door on questions. The next and last best practice we'll talk about is this thing called teach back, which is really, really important. It's kind of similar to asking, what questions do you have? So teach back is a way to check for understanding at the end of a interaction with somebody. And usually the way we're doing that is through these closed-ended approaches like, hey, do you understand? Does this make sense? Do we have a good plan? These are closed-ended phrases. And what do patients say when we ask this type of question? Particularly when they're confused, they're generally going to say, yes, I understand, right? They're going to hide the fact that they don't understand. Does that make sense? Yeah, it makes sense. Thanks. Yeah, seems like a good plan to me. Okay. And they thank us for our time and they leave. So we've really learned nothing by asking, does it make sense? What we really need to do is have them tell us back the plan so we know if there's a safe understanding, a reasonable understanding of the plan. So that's what teach back does. So teach back is a way to make sure that we've been clear with someone and that our message has been delivered. So an example here would be, I'd like to make sure that I've explained things clearly. In your own words, would you mind telling me back the plan? Or I know that I don't always explain things clearly, or I know that I sometimes talk too fast. In your own words, can you tell me back the plan to make sure I've done my job correctly? Another way to do it would be, how would you explain the new medicine to your partner when you go home tonight? Some other way to get the person to tell it back to you. This has really been identified as a top safety practice. It's been associated with better blood sugar control amongst people who have diabetes. It doesn't take longer than the usual approach. So it's a really effective, efficient, elegant way to cut through a lot of the issues here. I'm going to show you just one quick example of a teach back that combines using teach back plus creating an after visit summary in the patient's own language. And I'm going to just fast forward us to the end of this encounter to get to the point where this teach back example is. Understood them adequately. Now, to make sure I've done my job well and explain things clearly, if you will tell me back the plan, I'm going to type it on your visit summary here, and then I'll send that home with you.
Okay.
All right?
Okay.
Okay. So, for your blood pressure, what are we going to do?
You're gonna do some tests to check out my heart.
That's right. Yep. So test today. Okay. All right. And then what?
You're gonna call me with the test results.
Yep, that's right. Call you. Okay. Yeah. And then what?
And then, oh, you want me to come back in a week, I think?
Yeah, a week or two.
A week or two, okay. And so do I need to make an appointment for that?
Yes. So you need to make that appointment before you leave today.
Okay.
Okay. And 1 to 2 weeks is fine.
Okay.
Okay. So just another example. So now let's move on from there and talk a bit about how we can improve our communications with each other to help reduce any confusions, ambiguities, over extra work, and the like. So I'll start with an example of what I'll call a staff to patient relay message. So this might be a situation where maybe a provider is asking maybe a medical assistant to send a message to a patient, right? So this example could be me sending a message to a medical assistant. Please tell Chris I'm refilling their levothyroxine. All right. And what I want to point out then is um, that the person I'm sending this message to may not be familiar with something that I've put in this message, like the name of a drug or what it's for or how to even pronounce it. Maybe they are. In this case, maybe there's other examples we could think of. But that may make it hard for this person to relay the message or smoothly and comfortably to the patient. So maybe a better way for me to phrase it would be to anticipate that and to say, hey, please tell Chris I'm refilling their levothyroxine thyroid medicine. Right? So I put a couple extra words in there I put the context to basically what is levothyroxine, right? So I provided a definition for it, some context. Now, if the person's, let's say, not familiar with this medication or is not confident in how to pronounce it and doesn't want to feel embarrassed on the phone, for example, all they have to say is, Dr. Coleman said he's refilling your thyroid medicine. Do you have any questions? Or we should say is what questions do you have, right? Let me show you another example. These are real examples from the clinic. Please let Alex know their BMP was normal. So this was a message that was routed to a medical assistant. Now, BMP is a jargon term. It's an acronym. So all acronyms are jargon in medicine. But it stands for Basic Metabolic Panel, which is its own form of jargon, which many staff who may be calling this patient may not have had an occasion or reason to understand the components of it or what it means or how to interpret it for the patient themselves, right? And with our professional roles at the clinic, some of us will not be able to interpret some of these phrases and will be asked to pass them along to the patient verbatim, right? So if I pass this message along to a medical assistant, often or generally speaking, they would state the same thing verbatim to the patient using the term BMP for the patient. The patient's not going to know what BMP is and what it means and what it means for them and what they need to do. So I could rephrase this in a better version by saying, please let Alex know their blood test was normal. Their kidneys are working fine, which is what the BMP is measuring. They don't need to do anything right now. Keep taking all the medications as prescribed. So now we've gotten rid of the jargon piece, we've given that additional context, and really importantly, we've helped anticipate the questions the patient may ask our medical assistant who's relaying the message, and now that person can actually respond if they need to. Here's another tool that we can be using called SBAR, which you may have heard before and may have seen used in the clinic or may use yourself. SBAR has been around for quite a while. It came out of the US Navy as a communication tool for helping reduce errors and accidents, which could cause injury and death. And they found it to be effective there, so it's moved into other aspects of communication outside of the military. SBAR stands for Situation, Background, Assessment, and Recommendation, which sounds very militaristic, but it helps break down any kind of message into really helpful, useful categories so that the person receiving the message can find what they need really quickly without ambiguity. So here is my dot phrase, .sbar, which I use to send messages about phone calls and other things that I'm routing. And you're welcome to take this dot phrase and adapt it if you'd like. So let me show you an example. So let's say the situation is that I receive a refill request for the medication metformin. So I might say, well, the situation is a refill request for metformin, the diabetes medicine came in, and provide a bit of background. The background was that this person came in and they had their last hemoglobin A1C test for diabetes back 6 months ago. So my assessment is that they're now due for this test. I would like to get it done. My recommendation is I'll go ahead and refill this, but please schedule them a non-fasting lab appointment and they can come in and get this test done. So hopefully the messaging there is very clear about what's being asked, and the person doesn't have to read a lot of it. If they just want to go straight to the recommendation, they can go straight to it and figure out what needs to happen for efficiency's sake. Here's a similar dot phrase that I use specifically for lab results to help break things down in that same kind of way, provide some background and context to help answer the patient's anticipated questions. So .cc results, you're welcome to take this and modify it if you'd like, or just make your own. And we'll use that old example that we used before, but we'll now apply it to this. We'll use this dot phrase to kind of break it down. So please let Alex know their BMP was normal, was what we looked at before. Let's put that into this dot phrase. So it'll say GreenPod MAs, please contact this patient regarding their test results, major results. Might not put all their results in here, but maybe the main ones that I want them to be conveyed to the patient now. The blood test for kidneys, I put it in parentheses to kind of define it here. Basic metabolic set was normal. So we've gotten rid of that BMP jargon by defining it. We said this is a test for kidneys. We've recognized the fact that if I had just said BMP, then that expectation would be that that was exactly the language that the medical assistant would use with the patient, and that's not going to be helpful for our patient. The background is we did this test to make sure that their blood pressure medicine, lisinopril, was not hurting the kidneys. This is why we ordered this test 2 weeks ago. The assessment now is that everything looked good. We don't need to change anything. And our recommendation is keep taking the lisinopril every day. The plan for follow-up then is please schedule in-clinic visit 1 month to recheck blood pressure. So we've anticipated the patient's questions, well, what do I need to do with this information? Just keep taking the pills and come in a month. And we've broken things down, systematically organized it for clarity so there's less ambiguity. So I'm going to stop there. Thank you for your attention. Have a good rest of your day. And I will now continue on and show you some additional resources, which you can look at some video and some readings. Now, this is a 10-item optional post test, which you're welcome to take. Just pause on each question until you're ready to move on. The answers follow the test questions. And here are references to the materials cited in this talk.